The CDC's Morbidity and Mortality Weekly Report has released its intermediate data for the October 2025 to April 2026 influenza season. For specific vulnerable demographics, this pathogen remains a severe, immediate biological threat. The headline statistic driving public health policy this season is the overall vaccine effectiveness, which is estimated to sit between 50 and 60%. Within the highest risk demographic, patients between the ages of 40 and 70, the average effectiveness is pinpointed at 55%. This model illustrates exactly how vaccine effectiveness is calculated. It measures the relative reduction in infection and severe outcomes when comparing a vaccinated cohort against an unvaccinated cohort. It does not measure absolute immunity. A severe epidemiological risk arises when clinicians assume this 55% average applies uniformly to every patient across a 30-year age span. Treating this metric as a monolithic population-wide guarantee obscures the specific vulnerabilities of high-risk patients. To find the actual clinical truth, we have to fracture these broad population averages into distinct granular cohorts. Implementing a functional public health strategy requires us to deconstruct this average and map the age-stratified efficacy gradient. Identifying exactly where and why the vaccine's protective envelope degrades is the only reliable way to build a clinical defense. We can break down the CDC data into 3 targeted age decades: patients in their 40s, 50s, and 60s. Starting with the youngest cohort, the 40 to 49 group establishes a baseline peak at 60% effectiveness. This aligns with a robust immune response, rapidly neutralizing viral antigens. Moving to the 50 to 59 cohort, efficacy drops to 55%. This decline correlates with the onset of chronic comorbidities. This initiates immunosenescence, the natural deterioration of the immune system. Finally, in the 60 to 70 group, protection bottoms out at 50%. This marks the critical intersection where advanced immunosenescence and underlying diseases limit the vaccine's impact. The data reveals a strict inverse correlation. As clinical vulnerability increases with age, the biological efficacy of the vaccine systematically decays. Because biology forces efficacy to drop precisely when patients become the most vulnerable, clinical strategies must adapt to fill the gap. We have to ask if this 50 to 60% range is an absolute biological truth, or if it is skewed by statistical estimation. The data carries 2 primary limits. The first is mechanical, the frequent and unpredictable mutation rate of the influenza virus itself. Through a process known as viral drift, physical biological mismatches routinely occur between the engineered vaccine and the actual circulating viruses. When predictive models fail to perfectly align with these mutating strains, biological efficacy drops across the board, regardless of the patient's age. The second limit in the CDC's observational data is entirely human. It is known as observation bias. In observational studies, populations separate naturally into vaccinated and unvaccinated pools. Those seeking vaccinations typically possess higher health literacy, maintaining proper diet, exercise, and hygiene. These supplementary behaviors act as confounding variables, artificially pushing success metrics higher. This bias suggests that raw observational data overestimates the vaccine's isolated immunological efficacy. Because the metric is clouded by both viral drift and human behavior, clinicians cannot ethically rely on the vaccine as a solitary shield. Knowing these data limits allows us to design an actionable clinical response. A declining vaccine effectiveness dictates strict behavioral compensation from both patients and healthcare providers. This timeline highlights the critical temporal baseline. October serves as the mandatory vaccination cutoff point. Securing the vaccine before the season's exponential growth maximizes protection. To address deficits in the 60 to 70 cohort, the protocol branches into additional layers, starting with mechanical barriers. This age group must adhere to strict 20-second hand-washing protocols to mechanically offset the drop in biological efficacy. Triggered by symptom onset, the final layer of defense is entirely reactive. At the very first sign of respiratory symptoms, fever or cough, rapid diagnostic and therapeutic interventions are necessary.
these measures must be fast and decisive to prevent severe progression. For older demographics, the vaccine serves as the primary anchor for a comprehensive, multimodal defense strategy.
To communicate this effectively, practitioners must address the binary protection fallacy. Patients routinely misinterpret the data, viewing a 50% vaccine effectiveness as a failing grade, or treating it as a simple coin flip against infection. Clinicians can counter this hesitancy by clarifying that the minor risk of a short-term, low-grade reaction is vastly outweighed by the mitigation of severe outcomes. This matrix reframes the goal. The vaccine provides systemic severity reduction, buffering against hospitalization. Returning to our age-stratified chart, we see behavioral compensation at work. Adding supplemental interventions equalizes the total risk profile across all age groups, despite dropping vaccine efficacy. This combined approach alters clinical outcomes at the population level, actively keeping vulnerable patients out of the hospital. Compounding protective layers create a durable defense that a single intervention cannot provide. The 2025-26 CDC data establishes the flu vaccine as a foundational risk reduction layer that requires additional interventions to achieve maximum efficacy. Public health practitioners must use this stratified data as a map for targeted clinical action, rather than interpreting it as a warning of failure. By defining the exact, age-stratified limitations of our tools, we can deploy interventions precisely where the data demands them.